So this is again another paper by Kate Wiles. She was one of the persons who attended our ADKI. So the impact of CKD on stage 3-5 on pregnancy outcomes, by and large, this is a 2020 published data in NDT. 178 pregnancies in 159 people. All of them had above CKD stage 3 or so. 98% had a live birth rate. 26% delivered prior to 34 weeks, and 36% had low birth weight. If you look at the women, this is very important. 46% lost 25% of their GFR from baseline. So if somebody started off at 50 ml GFR, by the time the delivery happened, their GFR was down to 25 ml. Postpartum decline is equal to what they would have normally taken 2.5 years to reach that creatinine level. Whereas in a transplant setting, if a post-transplant lady becomes pregnant, by the time the delivery is done, the GFR drop is equivalent to 4.5 years of progression. So one of the most important things is the level at which they progress the minute pregnancy is in picture. So if you have a CKD lady, she becomes pregnant, you manage successfully, delivery, maternal outcomes, mortality wise, fetal outcomes are all very good, but they have very poor outcomes vis-a-vis their progression of CKD. They lose 2.5 to 5 years of life, which could have been a non-dialysis time. So this is a best practice position statement talking of what you should do with CKD people. I will not go into the details. Please take all CKD people as those who are at high risk, and then you should start looking at them very closely. They have a picture. So if you have CKD stage 1, 2, 3, 4, there are recommendations how often to see them in your OP and what should you do at each time. Similarly, if you have proteinuria, depending on is it less than 300, more than 300, how often to see and what you should be doing. Hypertension, how do you take care of it? And then the drugs that can be used as first choice, second choice, third choice, and some drugs which should be avoided during pregnancy. So we will not have time to go through all this. You please know that risk of adverse pregnancy outcomes with women in CKD, mortality doesn't increase, but then the progression of CKD is very fast. So to conclude the CKD segment, women with CKD can become pregnant. Hypertension is universal. Progression of CKD or decline in GFR is very fast. They will lose somewhere between 2.5 to 5 years of non-dialysis period. Proteinuria always worsens, so you will have to have strategies to control the protein loss. Autoimmune flares have to be managed by increasing and changing the type of immunosuppressive agent that you are doing. Premature delivery is very common, IUGR is very common, whereas mortality is not high, both maternal and fetal. So if you shift gears and look at the acute, this is a lady who was 33-year-old, full-term normal delivery elsewhere, had PPH and renal shutdown, supported on hemodialysis. 2 weeks later, she had a biopsy. Anybody? What is there on the biopsy? You will find that the entire architecture of the glomeruli is totally lost. What you call it as ghost glomeruli. And this is classically seen with loss of cellular details and some fibrin thrombi. So this is classically seen in cortical necrosis. And many of us think cortical necrosis is not very common. I'm going to show you some data from city of Hyderabad. So again, you see this particular lady had normal renal functions in delivery, had an acute shutdown, and straight away has gone to CKD stage 5. So in other words, when you have AKI in pregnancy versus CKD who gets pregnant, they are quite different. AKI in pregnancy, once it happens, the outcomes are not good. The drop in GFR can be very steep. I already mentioned to you the background. Their reserve is very less. Every pregnant woman, that's true. And they can get to ESRD very, very fast. So this is data that we had done some screenings between 2015 to 2020 in urban slums of Hyderabad. CKD incidence was around 14.8. As you can see, unlike ester years, the females are actually more than the males. And if you look at One of the major reasons for CKD in the women population is obstetric AKIs which are not managed well or allowed to progress to CKD. Most important reason being, when they deliver, they are lost for follow-up. They think everything is fine, but that's not true. Most AKI, by the time delivery happens, gets into a spectrum of chronic kidney disease, and they are asymptomatic. If you don't follow them up, you will progress very fast into dialysis stage, and I will show you some data.